I welcome you to this morning's session on TAVR Key Issues 2025. Moderating this session together with someone that doesn't need any introduction, Dr. Leon from the United States. The panelists are mostly assembled here. I don't need to mention their names, you all know them. And Marty, without further ado, welcome to Seoul, to this wonderful meeting, 30th anniversary. Please, we're listening to your lecture. Thank you, Marty.
Eberhard, thank you so much. We have a very distinguished panel, and we have a relatively short period of time, and I've been asked to do the impossible, to try to summarize all of innovation in TAVR for the next decade, so I'll do my best. I will be very selective, and excuse me if I forget certain things, but I'll give you at least some sense of what I think are the highlights. So I'm going to cover these 6 areas, give you a little background, talk about expanded clinical indications, some issues relating to TAVR technology, focusing a little bit on durability, some of the TAVR accessory devices, this concept of precision modeling to improve outcomes, and then, not something so commonly done by interventionalists, to talk about TAVR pharmacotherapies, which I think are going to be very important in the next decade. So, background. TAVR is now mature, with high expectations for excellent safety and efficacy in most patient subgroups. Ease of use, efficient workflow, and rapid discharge have resulted in generalizability in most environments, although reduced access to care does remain challenging. There's now a shift in focus to what we call lifetime management of aortic stenosis, and integrated artificial intelligence will be a major source of TAVR innovation in the future in many different ways. This concept of lifetime management means that we don't just focus on the index procedure, we also think about what we have to do to improve the diagnosis, to consider what we call preemptive treatment, and also to consider how we can treat some of these patients with pharmacology at an early stage. And then after the procedure, we worry about durability, we worry about non-responders, and we worry about other concomitant diseases. So this is now part of the way we think and where the future is going. We got involved in some of the issues relating to early diagnosis of aortic stenosis, but the first work was done in South Korea, looking at ECGs and demonstrating that algorithms could be developed using artificial intelligence with a high degree of sensitivity and specificity to indicate aortic stenosis. We've extended those observations over the last 7 years at Columbia with the bioinformatics group and have organized a cardiovascular data mart, looking at 12 million ECGs, 1.5 million echocardiograms at 8 hospitals, with the data sanitized, tokenized, validated, and harmonized in such a way that we now have a predictive model from a 12-lead ECG, from 10-second 12-lead ECG waveforms of a prediction score that has been internally and externally validated and is now being applied. So every patient that comes to any of our hospitals at New York Presbyterian, the ECGs are analyzed to see if they have a high predictive score for structural heart disease, and if it passes a threshold, these patients are triaged for early evaluation with echocardiography, and if necessary, referral to a valve center. These kinds of things in the future will improve some of the issues about access. Briefly, expanded clinical indications. Clearly in the next decade, TAVR will expand to younger patients, more bicuspid aortic valve disease, an increased number of TAVR failures or redo cases, you just heard that, the concept of acute decompensated aortic stenosis, this other concept that we now call preemptive asymptomatic severe aortic stenosis, or, and you'll hear later this morning, at-risk moderate aortic stenosis, and also predominant AR categories that are very common in Asia, even more so than aortic stenosis in some locations. These are some of the clinical trials that are being started right now. Navigate, the largest ever randomized trial in bicuspid disease, an international study of 1,500 patients. We know and predict in this work that was done by Philippe Genereux that by 2028, we'll have more recurrent TAVRs due to degenerated SVD than we will surgical valves. So this will become a big issue that needs to be addressed. Early TAVR you'll hear about, which I think is one of the most important clinical trials done in cardiology over the past decade because of the many issues that it has raised. And the ARTIST trial, just beginning in the next month or two, looking at aortic regurgitation in a randomized trial versus surgery in a wide cohort of patients that could revolutionize the therapy of aortic regurgitation in the future. We need to talk about TAVR technology and some of the durability issues. The basic technology is well established. Low-profile systems, either balloon expandable or self-expanding frames, predictable deployment, optimal coronary access with commissural alignment if possible, an external skirt that gives you mild or less PVL, low PPI rates, and acceptable hemodynamics. That should be the requirement, the bar. But we're seeing now iterative TAVR refinements that will continue to focus on specific features that I'll review in a moment, and you're going to see major breakthroughs in leaflet durability, we believe. So this is the interesting Anteris Dur-AVR TAVR system. It's meant with a short frame balloon expandable device with a monoleaflet design have excellent or superior hemodynamics, which potentially could improve durability. And in the earliest work that's been done in the early feasibility study, this was confirmed in our own Echo Core lab, it was striking to see how good the hemodynamics were for an intra-annular balloon expandable platform. This is the Siegel balloon expandable THV system. This focuses on a completely different frame alloy with commissural alignments, interesting leaflet morphology, nitric oxide coating on the frame, and delivered on a balloon through an 8 French expandable sheath. This new alloy called molybdenum rhenium has 3 times the strength and durability of the cobalt alloy valves. It is nickel-free. There is absolutely no recoil, and we think this may have an important impact in the future. There is new tissue being applied, and you're all familiar with the Edwards Resilia valves that initially were introduced in the Inspiris device. This is stable capping of the exposed aldehydes with glycerolization that allows you to dry leaflet store these devices. They've now been placed on 5 different surgical and transcatheter platforms, and some of the early work with Sapien 3 Ultra Resilia TAVR through the first year indicate improvements in clinical outcomes and also hemodynamics in a large propensity score match study. And to me, perhaps the most exciting, and this was introduced by Junbo, is a true polymer valve. And this is the Tria Foldax siloxane polyurethane valve that has now been used in surgical valves and is being developed for transcatheter valves and is made using a very interesting robotic manufacturing system that would allow marked reduction in the cost of developing these systems. TAVR accessory devices are fascinating. The emphasis is now shift to accessories to reduce complications and expand clinical indications. Perhaps cerebral embolic protection is the most controversial. Leaflet modification to protect vulnerable coronaries during TAVR, and that's either electrosurgery or mechanical is currently the most fashionable, and there are many other things being developed. Guide wires, balloons, access closure, LV pacing that are fascinating. You're all familiar with the ACC presented British Heart Foundation Protect TAVI study, which in almost 8,000 patients indicated no difference with CEP versus non-CEP, but there were some interesting issues related to that study. It was at odds with an earlier trial that was presented by Samir Kapadia in 3,000 patients, where the US cohort showed a 50% relative risk reduction in all strokes and a 73% relative reduction in disabling strokes. So I think that the issue is not completely sorted out, and there are many new devices using very interesting clinical trial designs, and Alexandra Lansky will explain some of these, that I think are fascinating and that are ongoing. This is the first FDA-approved mechanical device for leaflet splitting. It's called the shortcut device. Right now, it's only been exposed to a registry analysis, but a fascinating device that may significantly simplify and modify our approach to managing leaflets. I want to finish by talking about 2 topics, precision modeling and then pharmacotherapy. Computational modeling from CT imaging using AI algorithms now can assist with device selection, device positioning, simulations to prevent complications, and they're being used frequently in many centers in bicuspid disease, particularly if it's heavily calcified, valve-in-valve and TAV-in-TAV procedures, and in other complex anatomies. There are many different players. There's Dossier simulation, there's FIOPS, there's Laralab, and there's increased use now of 3D printing in selected complex cases. This is an example of a case we did in New York with a very heavily calcified bicuspid valve where we were worried about paravalvular leak risk, and we had a much better image to be able to predict that, where we did a stretch analysis to see if we had a risk of perforation. And again, these new techniques, when they get simplified and they're used more generally, could have an important impact in how we manage patients with complex morphology and maybe more routine in doing procedures like Redo-TAVR and TAV. And finally, integrated pharmacotherapies. After decades of frustration, advanced pharmacotherapy development, I feel, will improve patient management and focuses on two things: delaying the progression of calcific AS and treating the consequences of valve-related cardiac remodeling, especially in what we call non-responders. I wouldn't presume to try to discuss with you the pathophysiology of AS, but as of today, there are no known proven medical therapies to slow or prevent the progression of calcified aortic valve disease. I will tell you now the leading major candidate is modification of Lp(a). This is a very common finding in certainly in North American population. Currently available drugs only modestly achieve reduction in Lp(a), and there are phase 1 and 2 trials ongoing now with an interesting study using pelacarsen, which is an antisense oligonucleotide, looking at a complex study that certainly will give us insights into whether or not we can modify, using imaging techniques, echo and CT, the progression of calcific AS. And finally, medical therapy for aortic stenosis should focus on the ventricle because of maladaptive cardiac remodeling to protect the pressure-overloaded heart while AS progresses and to augment LV recovery after AVR. There are many contenders, although SGLT2 inhibitors seem to be the lead candidates right now. And interestingly, just a month ago, DAPA, in a randomized trial in the ACC, was shown, as you can see here, to delay the progression of aortic stenosis in an interesting population of patients with mild or moderate aortic stenosis. So we think this concept of evaluating medical therapy for calcific AS is important. There'll be many new and interesting clinical trial methodologies applied to this, and ultimately our goal is that we'll be able to take all patients with aortic stenosis and triage them into either multi-drug precision medical therapy or, based upon a variety of clinical trials that we've done, other transcatheter approaches, some preemptive, some reactive to symptoms, in order to really have a total impact on aortic stenosis. And we should see all of these things mature in the next decade. And if you want to learn more about this, please come to New York in June to the New York Valves meeting. Thank you.
Thank you very much, Marty. Excellent as usual. And we move on to Philippe, talking about the asymptomatic severe aortic stenosis. Philippe, welcome. Listening to your early TAVR trial again. Thanks.
Well, first of all, thank you so much for having me here, and congratulations to TCTAP for the 30th anniversary. It's a pleasure to be here with friends. And indeed, I'm going to talk about early TAVR trial for severe AS no symptom patient and a couple of lessons learned from this trial. So this trial was published in New England Journal of Medicine with many co-authors on the podium. So first of all, it was by far the largest trial on the topic, randomized controlled trial with severe AS no symptom patient, 65 years old and above, STS score 10 or less, and LVEF 50 or more. The one thing that made this trial very rigorous is everyone had a low-level treadmill stress test to ensure that we were truly asymptomatic. After that, everyone had a CT scan to make sure they were TF-TAVR candidates suitable for the S3 or S3 Ultra valve, and then they were randomized to either clinical surveillance per the guideline or transfemoral TAVR. The primary endpoint was superiority endpoint on all-cause death, any stroke, or unplanned cardiovascular hospitalization at a minimum of 2 years follow-up. This is probably one of the first messages that we extract from early TAVR. We screened more than 1,500 patients over the course of 5 years. 42.9% were excluded And the vast majority of them, so 20%, were excluded because they already had a class 1 indication for AVR. Either they had symptoms positive on the stress test or a large aorta, and they already had a class 1 indication for AVR. So very important, 20% of the patient community already have a class 1 indication they don't even know. Then 15% were excluded because they were not suitable for TAVR. So maybe surgery is better for those patients. So 901 patients were randomized to either TAVR or clinical surveillance. You see the baseline characteristics, 76 years old, so not necessarily younger population, but 76 years old, 30% female, 15% were high risk or intermediate risk with 85% low risk. 90% could perform a low-level stress test. And look at the key CCQ score, 93 points. Those patients were clearly asymptomatic and happy patients with no symptom at all. And 8% were bicuspid. You see the echocardiographic characteristic, truly concordant severe AS with high gradient and a really normal AF 67%. This is the primary endpoint that you saw on the death, stroke, and implant cardiovascular hospitalization. Early TAVR was associated with 50% reduction in the primary endpoint, with a number needed to treat of 6 patients to save 1 event at 2 years, with a median follow-up almost of 4 years. There's no difference in mortality, and we're going to discuss why we didn't appreciate the lack of mortality between both groups. And you can see there's no difference in stroke, but you can see a trend to higher risk of stroke with clinical surveillance that seems to accentuate through time. And I think this is a finding that we should not sleep on, which is extremely important for me. Obviously, we won mainly because of unplanned cardiovascular hospitalization, and we're going to see what were those unplanned cardiovascular hospitalization in the next slides. There were consistent benefit of the early TAVR strategy across all the pre-specified subgroup, including peak velocity more in less than 5. If I have to redesign the trial, I think I will choose this endpoint. And this is, again, I think the second most important slide of the slide deck. And we look at the composite of death, stroke, and heart failure hospitalization. And heart failure hospitalization was defined as the need for IV diuresis in the hospital, inotropic therapy, balloon pump, the need for ventilation, or dialysis for overload. And you can see a 40% reduction with early TAVR strategy compared to clinical surveillance. We also had a list of pre-specified secondary endpoint, and we can see that early TAVR strategy was associated with favorable health status outcome, which was a great quality of life and being alive at 2 years, 86% compared to 68%, and also with better integrated LV and LA health at 2 years, so less cardiac damage at 2 years with early TAVR compared to clinical surveillance. So this is probably the third message. The third message, which is very important with early TAVR, is the natural history of the disease. So among patients that were randomized to waiting, at a median time of 11 months, they need a valve. And you can see that 26% of the patient at 6 months met a class 1 indication for a valve, 47% at 1 year, and more than 70% at 2 years. And what were their symptoms? So we're going to have a deep dive at New York Valve on those, but you can see, no surprise, 83% come with shortness of breath, and 30% of them came with severe heart failure, class 3 or 4. And I will take your attention to almost 7% of patients had syncope. So if you take the syncope in a class 3 or 4, almost 40% of the patients had very, very severe symptoms. Then what we did, we classified patients based on the type of presentation they had when they convert to AVR among the group randomized to waiting. So we classified them as either were they still asymptomatic, so only 2%, 9 patients were asymptomatic at time of conversion. Did they have mild symptom or progressive valve syndrome that we call, mainly class 2 heart failure? Or did they convert with advanced and acute symptom, what we call acute valve syndrome, similar to ACS, so AVS, with class 3 or 4 heart failure, syncope, arrhythmia such as ventricular arrhythmia, pulmonary edema, cardiac arrest, resuscitated, a drop of VF, or a lot of increase in NT-proBNP. And what we saw among people that were waiting, 40% of those patients present what I call acute valve syndrome or crash and burn scenario. 60% present with more progressive symptoms or progressive valve syndrome, and only, like I said, 9 patients were still asymptomatic, but all had either class 2A, 2B indication or the need for other non-cardiac surgery. one of the key points is the proportion of those patients that came with acute valve syndrome was consistent through time, including 0 to 6 months and beyond. So this crash and burn scenario where acute valve syndrome is consistent through time and very hard to predict, as we tried to do at ACC, and we failed to be able to predict this acute valve syndrome. So if I have, again, to redesign this trial in the future, maybe another life, I will probably choose this endpoint as well, which is a composite of death, stroke, and unplanned hospitalization, mainly due to acute valve syndrome. And you can see, again, this 50% reduction with the early TAVR strategy, which I would say are much more pleasant to the eyes curve that like progressively separate and will not raise suspicion. So why we didn't see any difference in mortality? Because in early TAVR, unfortunately, we were too good. The promptness of treatment in early TAVR was quintessential. You can see that if you were randomized to early TAVR, in an average 14 days you had your TAVR. And if you were randomized to waiting group and you had symptom or you needed conversion to a VR, within 32 days you had your EVR. And 90% of the patient actually had their VR within 90 days, which actually it's never seen before and probably not to be replicated in real life. And when you see actually also the reason why we didn't have mortality in both group is both group has excellent outcome. Look at the cardiovascular mortality, early TAVR is 0%. And even in the conversion group, 0% mortality at 30 days for the AVR. So we had really, really good outcome. Look at the stroke, 0.9% for early TAVR, 1.8% for delay AVR. Pacemaker, 5% compared to 8% with delay AVR. So you can see good outcome in both groups, but I cannot resist to see that there's a little bit worse outcome with the delay AVR. So what are the lessons learned with early TAVR trial? First of all, 20% of asymptomatic patients already had a class 1 indication for AVR. I believe that early referral and early procedural planning improved outcome in both groups. We were ready. 50% of the patient will need AVR within 1 year, which is very important for shared decision-making discussion with the patient. 40% presented with advanced symptom, what we call acute valve syndrome. There's no penalty for early TAVR or AVR in this trial. If you put the long list of pro and cons for waiting, there's no pro. I believe that prolonged exposure to AS seems to be associated with increased stroke risk, and I think that's when we need to pay more attention to this. And prompt treatment within 3 months of symptom initiation may mitigate mortality risk in the waiting group. So what I said to my patient after early TAVR, because they all come in, they want their valve fixed, first of all, I reassured them. I said, it's good that you see me first because we're going to get organized. We're going to put our ducks in a row. We're going to get a CAT scan. You're going to fix your teeth, and you're going to get ready for the TAVR date, like a wedding. Okay, one year to plan the wedding, not the day before. Plan your AVR date ahead. If you want to wait for symptom because you're contrarian, fine, but you have to be able to treat within 3 months. There's no way you're going to say, I'm waiting, and if you cannot treat patient within 3 months of symptom initiation. And again, there's no penalty for early intervention. So I'm going to stop here. Thank you so much.
Philippe, that was great. I'm sure we'll have some questions, which we're going to defer until the next two speakers. Our next speaker is a good friend, David Joel Cohen. I didn't know your middle name was Joel, David.
I didn't know yours was Bert.
David's going to talk about a topic that's very interesting to us. I must say Nick Van Meegen would love to be here as well because he has been passionate about this. But treating TAVR for moderate AS and heart failure, and discuss the TAVR Unload trial.
Thank you, Marty, and thanks to the organizers. It's really great to be here for the 30th year, and I'm sure this is really supposed to be Nick Van Meegen. I don't know why he's not here. He should be. These are my disclosures. So historically, we've all looked at this figure, everybody in medical school, and talked about this sort of long latent period with moderate aortic stenosis that eventually progresses to severe in symptoms, and Philippe is trying to change this figure as we speak. And in the last decade, there have been a number of studies starting to suggest that moderate aortic stenosis may not be benign. One of the bigger ones and more well-known is this study from Australia where they looked at 240,000 patients in a national echocardiographic database and categorized them according to AS severity. And what they found is a graded relationship between the severity of aortic stenosis and long-term mortality or survival. And what you can see here, the purple curve is the moderate AS group. They have a curve that's almost superimposable on the severe AS group. And if you look at the adjusted hazard ratio after adjusting for age, sex, and other comorbidities, you can see that somewhere between mild and moderate, that risk starts to take off, raising questions about whether treatment of moderate aortic stenosis could make a difference. And another thing that has come out from some other studies is that this relationship between moderate AS and prognosis seems to be accentuated in patients who start with a lower ejection fraction. And so that really was the background on which the TAVR Unload trial was built. It started with patients with heart failure with reduced ejection fraction on guideline-directed medical therapy who had moderate AS defined very rigorously as an AVA greater than 1 but less than or equal to 1.5. You could use dobutamine or an indexed AVA less than 0.9. The trial ended up with just about 180 patients randomized 1-to-1 to transfemoral TAVR with the balloon expandable valve or to clinical aortic stenosis surveillance. The primary endpoint was a hierarchical composite, all-cause death, disabling stroke, hospitalizations and equivalents, so heart failure worsening, and then the change in the Kansas City cardiomyopathy questionnaire. And then the first secondary endpoint was all-cause death, all stroke, hospitalizations, and equivalents. So who did the patients end up being? This is the baseline characteristics. You can see here just a couple of highlights. They were older patients. They were in their late 70s. Most were in class 3 heart failure, but not felt necessarily to be due to the aortic stenosis. And about half of them had had at least one heart failure hospitalization in the previous 12 months. From an echo standpoint, you can see here, these were true moderate aortic stenosis, valve area of about 1.2, 1.3, low gradients. Remember, these patients have depressed ejection fraction to begin with, and they don't have severe AS, so they had gradients right around 20, and the ejection fraction was about 40. So a group that is around and fairly common that we would encounter. So the first important finding of this study, and it's a little bit like what Philippe just described, is that by the end of 3 years, there was nobody in this study who either wasn't dead or had their aortic valve replaced. You can see here at the bottom, these are the patients who received TAVR, and then the blue on the top are the patients who died without a TAVR, and you can see that about 60% of the patients got a TAVR in this surveillance group, and about 40% died before they had a TAVR. And these were all for progression to severe aortic stenosis documented by echocardiogram. This is the primary endpoint expressed in terms of a win ratio. So higher is better. So TAVR is here on the left and clinical surveillance on the right. So for mortality, there was no real difference. For disabling stroke, very low rates, and this is at the longest follow-up. There was a slight trend towards better outcomes with TAVR for hospitalizations and equivalents, and again, a trend in the terms of the Kansas City cardiomyopathy questionnaire. And when we looked at the full extent of follow-up, again, there was a trend in favor of TAVR. The win ratio was 1.31, but it was not statistically significant. Interestingly, if the investigators had stuck with the primary endpoint as originally defined, which was going to be assessed at 1 year, it would have won. The endpoint was changed prospectively before any of the outcomes were known because the sample size was much lower than the original intent to try to increase the power, but it actually would have won had the trial been executed exactly as it had been originally planned. Looking specifically at the clinical outcomes, you can see death, stroke, or heart failure hospitalization, really no difference at all over time. All-cause mortality, absolutely superimposable curves. What did differ is the quality of life. So you can see here the change in quality of life from baseline over the extended follow-up period. And you can see, obviously, there was a jump, a fairly large jump in the patients who were treated immediately with TAVR. And then there was sort of gradual decline over time as their heart failure started to get the best of them. On the other hand, if you look at all the patients in the surveillance group, they had just a small bump initially, and then they tended to go up. And why were they tending to go up and get better? Well, some of it is because of attrition. Some of the patients are dying, and they tend to be the sickest. And so even if nothing was happening to the other patients, they would actually start to look healthier. But what was also happening was crossovers. The crossovers to TAVR, which would then improve the quality of life in these patients. And you can see at the end of 2 years, there was about a 4-point difference, which is really a fairly small to moderate sized difference. But if we censored the KCCQ, if we said, let's just stop following these patients in the control group when they crossed over to a TAVR and just follow the ones who continue to be treated medically, you see a very different story, which is there isn't this progressive improvement in the surveillance group. It stays very low, and the benefit persists all the way out to 2 years. So we do think that I think the crossovers, just like in the early TAVR trial, made a difference in how we interpret these outcomes. There are several, as Marty mentioned already, ongoing trials of TAVR in moderate aortic stenosis. There is the PROGRESS trial, which is with the balloon expandable valve, as you see here, moderate AS with symptoms or cardiac damage and dysfunction with preserved ejection fraction, so the other side of the coin here, but again, a moderate aortic stenosis group. And then there's the EXPAND TAVR 2 trial, which is being done with the Evolute platform. Again, patients with moderate AS, EF that is not overly depressed, but still could be fairly low, symptoms, and again, one or more enrichment factors for increased events. The enrollment in PROGRESS has been completed, and rumor is that next year, at some point, we may have the results of that, and enrollment is ongoing still in the EXPAND trial. So my summary and conclusions from the TAVR Unload trial is that at this point, based on multiple studies, it's clear that moderate AS is associated with excess mortality and heart failure hospitalization, particularly in patients with reduced ejection fraction. But it remains unclear whether treatment of moderate aortic stenosis really affects these outcomes. On the pro side, we have some observational data that suggests a graded relationship between the severity of AS and outcomes, which suggests a cause and effect. And this may be mediated by progressive extravalvular cardiac damage, again, an area where Philippe has made major contributions. On the con, the randomized trials haven't shown a benefit yet, at least on the primary endpoint, and the adverse outcomes may actually be driven by other things that are coexist with aortic valve disease, such as vascular disease, and particularly possibly mediated by something like Lp(a). And it's also possible, and I think entirely conceivable in these trials, that the excess mortality may actually reflect unrecognized conversion to severe aortic stenosis and then a failure of surveillance at some level. For now, the guidelines recommend, and I think will continue to recommend, surveillance with AVR only for AS progression at the time or the need for other cardiac surgery, and hopefully the other ongoing clinical trials like PROGRESS and EXPAND will provide additional insight regarding both the clinical and quality of life benefits of preemptive TAVR. Thank you very much.
Sorry, yes. Philippe Garot is going to be our next lecturer, and he's going to talk about updated approval randomized trials for novel TAVR devices, focusing on the ACURATE IDE trial and more. And Philippe was just with us in the previous symposium and has really become one of the leading clinical investigators in TAVR in the world.
Thank you very much, and thank you for the organizers for inviting me to this meeting. These are my disclosures. So let's start with the ACURATE IDE trial. As you know, this trial has been, the primary endpoint of this trial has been presented recently at TCT meeting, and 1,500 patients with symptomatic severe native aortic stenosis were randomized to ACURATE neo2 or to a mixed control with 2 SAPIEN and 1 Evolute. And the primary endpoint of the trial was a composite of all-cause mortality, stroke, or rehospitalization at 1 year. This is the results of the primary endpoint, and as you probably know, the non-inferiority for the ACURATE neo2 versus control was not met in this trial, with an incidence of the primary endpoint of 16.16% in the ACURATE neo2 group and 9.53% in the control group. Interestingly, all the echographic features, and especially gradients and PVL, were as expected with the ACURATE neo2, very similar to that of the Evolute valve. And one of the explanations given by the investigators to explain this disappointing result was that approximately 20% of the patients in this group had underexpanded valve, and you can see that these patients with valve underexpansion had most of the adverse event during the follow-up, and especially a higher rate of stroke compared to those with a well-expanded valve frame. Another IDE trial that was recently presented is the Landmark trial. This trial was a prospective randomized non-inferiority trial comparing safety and efficacy at 30 days in patients randomized to MyVal compared to contemporary THV series, typically Sapien and Evolute 1 and 1. And as you can see, in this trial, the rate of the primary endpoint was 25% in patients receiving MyVal versus 27% in those receiving control. And the non-inferiority was met in this trial with a p-value less than 0.001. Interestingly, all the components of the primary endpoint were non-inferior between MyValve and other devices. And the other trial that was recently published is the COMPARE-TAVI. The COMPARE-TAVI is a randomized trial comparing MyValve to Sapien 3, only Sapien in this study. You can see 100 patients randomized 1-to-1, and there's interesting pre-specified imaging sub-studies with CMR at 30 days and CT at 30 days and 1 year. And once again, this trial showed non-inferiority of MyValve versus Sapien in terms of safety and efficacy, VARC3 derived criteria. And as you can see, when looking at the components of this criteria, we showed no difference between the two arms with a red flag for higher rate of moderate and severe aortic regurgitation at 1 year in patients treated with MyValve. So what about ongoing RCTs for novel TAVR devices? First is the START-YOUNG trial. This trial is a prospective randomized multinational trial comparing TAVR versus SAVR in patients with severe symptomatic aortic stenosis aged 65 to 75. And in this trial, the primary safety endpoint and primary efficacy endpoint were as defined by the VARC3 criteria at 1 month and 1 year respectively. We have there a CT imaging substudy with 522 patients having a systematic CT at 1 month after the procedure to assess the feasibility of a second intervention, of a second TAVR intervention. The collab will be ECO and CT at 1 year, 3 year, and 5 year for ECO and 30 days for CT. And as we speak, the first patients will be enrolled in this trial. Envision, I don't have a lot of information on this trial, but the trial has already started to recruit 250 patients. And this trial compared the new iteration of the Navitor Vision valve compared to clinically available devices in patients considered intermediate or low risk for surgical mortality. You can see that 1,500 patients will be randomized up to 80 sites in North America, and the primary endpoint is a composite of all-cause mortality and all stroke at 12 months after the procedure. Finally, and this was introduced by Dr. Leon, the Duraver device will be probably tested in a pivotal trial thanks to very encouraging results. You can see that 100 patients have been treated and almost 40 patients are now out to 1 year with consistent safety and efficacy. And there will be a pivotal trial comparing Duraver to commercially available devices in the near future. So my conclusion, recent RCT-ID trials showed very positive result for the MyValve THV in both landmark and COMPARE-TAVI trials. We had disappointing results from ACURATE-ID trial that failed to meet non-inferiority despite encouraging echocardiographic outcomes. And we have ongoing and coming RCT trials with MyValve, Navitor Vision, and Duraver for the near future. Thank you very much.
So we have a few minutes for discussion before we move to our next group of speakers. So maybe Philippe, if you're available, one quick question. What we're beginning to see now in Europe and elsewhere, certainly when I saw Junbo Gu's lecture on some of the China-based studies, there's going to be a plethora of new TAVI devices. And many of them are going to demonstrate non-inferiority using some of the rather simple composite hard clinical endpoints that we generally use. So how do you make a decision as a clinician in Europe when you have so many of these devices available about what device is preferred under what circumstances?
Of course, there's a lot of factors to make the clinical decision in routine. And I mean, one of the most important for us is to have first a discussion about patients' age and risk, thinking about lifetime management, of course, and then imaging, and especially CT, with all the features that we all know, with the risk for sinus sequestration, with the risk for high risk of complications. And then if we have a good combination of, I would say, risk factors related to the patient's condition and comorbidities and favorable CT features, the decision will be easier. But it's sometimes, in some patients, it's the opposite. I mean, sometimes you just have only one solution, and that's why it's so important to have all these imaging features.
I mean, obviously, these are important points. The question really is, how many valves do you need on on your shelf? You need one balloon expandable, one self-expandable valve. Do you need three? I mean, in Europe, we have the Genereux valve, obviously, for aortic regurgitation, so that's taken out of the context a little bit. At the end of the day, I think, lifetime management broadly comes down to durability issues, but durability can only be proven by durability. That's the unfortunate thing. So we have to wait 10 years in order to make a decision. Like the Dura, claiming that, better laminar flow, different tissues, the tissue workup, all these things you can claim, but at the end of the day, you have these acute, very, very good results standing against the two leaders, if I may say, the balloon expandable and the self-expanding valves. It's a very hard question to answer at this point. Do we need any more valves? Do we need, and how do we differentiate? I don't think that we can say this very clearly, Marty, except for saying, personal preference, price, relationship to companies, all these things play a role, very important role. And in other geographies, I think pricing is a very, very important issue that differentiates unless you have really inferior results.
Yeah, I think that it involves two different categories. First, I think you do need some baseline clinical evidence to demonstrate that you are reasonably close from the standpoint of non-inferiority. It was less encouraging with ACURATE Neo that now with 3 randomized trials, they could not make their primary endpoint. Yeah. Now, you can argue that there are many factors associated with that, but certainly you do need to have good clinical data. I agree that you can never have more than 3, maybe 4 of these valves in your lab. It's not like DES. They're not really commodities. I tell people that, that there are differences with people getting comfortable with one version or the other. So you have to have enough case density to be able to get experienced using the various valve types to get optimal outcomes. So it's more complicated with TAVR. And as we see all these new studies emerging, I think it'll get even more confusing in the future. Any other questions from any of the panelists?
I will just complete what you just mentioned. I think the first thing we do when we choose a valve, you need to look at a CAT scan and make sure that you can repeat a TAVR in the future. And that's, for me, the thing we learned by treating valve failure, TAVR failure, is you change completely your vision of the first TAVR implant. And when I see all those novel valves, for example, Anteris, well, for me, long leaflet means maybe more challenges to retreat those valves. So you need to have large sinuses, you need to have large STJ, you will need to make sure you can repeat those. So I think the CAT scan, the initial evaluation is key, not only for the index procedure, but also in the future, can I repeat a TAVR safely? And it's not only about acute gradient, it's not only about coronary access, it's about repeatability of the TAVR. So I think that's key.
Well, we're going to go on with the next group, but I just want to make one comment. I really listened carefully to David's presentation on TAVR Unload, which was a difficult study because this was really an investigator-initiated trial. We did have some industry funding, but we could not complete the study. So it had to be truncated early. So the results have to be considered with that reference point. And we had some unexpected findings. But I will say two of the things that occurred to me with moderate AS for at least people to consider or discuss is that as we were screening these patients, there's a higher likelihood in the moderate AS category of having low flow, low gradient AS. And that's trickier to diagnose. You need more dobutamine stress echoes. You need a good echo core lab in order to correctly categorize these patients. And it may be that that group behaves slightly differently. And the second thing is this rapid progression to aortic stenosis to severe AS was unexpected. And it's the same that Philippe had observed, the rapid progression from asymptomatic to symptomatic severe AS. I think we underestimate how quickly these diseases can progress. And when we talk about surveillance, we're generally talking about passive surveillance. You see the patient maybe every year, maybe you get an echo or you don't, it's not referred to a valve team. At the very least, even if you're not doing preemptive TAVR, you should apply, even now, active surveillance to these categories of patients, the asymptomatic severe and the moderate AS. So they're seen more frequently, they get good echocardiograms, and you're watching closely to be sure that you don't miss what is rapid progression.
Yeah, I would echo that, Marty, and I think even though we don't have any conclusive results, and as you described, the TAVR Unload met some difficult times or passed through some difficult times for various reasons. But I think if we kind of extrapolate from asymptomatic aortic stenosis, knowing that earlier intervention is better, and earlier intervention has better outcomes, why would that not be the case in moderate aortic stenosis? For me, it's hard to believe that this is different, particularly when you have heart failure symptoms. So from a clinical standpoint, advising patients, coming back to David's last slide, I would still recommend if I had a patient with moderate aortic stenosis and heart failure, I would still advise him to have a replacement instead of having clinical surveillance, even though it's not proven by studies. But I hope that the two that he described, the two balloon expandable and self-expandable studies will, have a better conclusion to move forward.
Maybe I just want to say one quick comment. When you follow moderate AS patients, especially with low EF, it's very challenging to follow those patients.
Yep.
Because we're waiting for what? We're waiting for a class 1 indication with severe AS. Those patients who have 3-time heart failure hospitalization before they reach out those magic gradient of 40 and AV less than 1. So I don't know what we're waiting for, because the echo, the waiting for the typical gradient or the standard severe AS severity by echo is very difficult. It's not happening. And all the 50% of the patients that TAVR Unload, they convert to what they say, quote unquote, severe, they didn't meet criteria for concordant severe AS. They were judged severe by the cardiologist, but they didn't meet criteria of severe, pure criteria by the core lab. So this is a challenge also in progress. Like they're going to have heart failure before they met the criteria, and then you're facing, should I treat the patient or let him die or let him have the 3 or 4 heart failure hospitalization? So those criteria need to be revised because it's unachievable sometimes. You're chasing something you cannot achieve.
Yeah, one comment to Eberhard. That's why we do studies. So it's to answer this question. So I think the studies should be embraced. But going back to the studies, in the study that Medtronic is right now running, we have trouble to enroll because of the gradient. We don't achieve the right gradient. So my question to any of you, should we drop the gradient completely and just look on the aortic valve area as the criteria? If you have a 1.2 and signs of heart failure, you hit the moderate AS tag, because the gradient is confusing, and I don't think we have a good hands on that. So maybe the trials need to rethink in terms of the design, because there will be more future trials no matter what Progress and Expand will do. So that's my feeling about Progress. Expand was able to do it, but they have a different criteria. These are not the same kind of studies. So again, I'm not sure how would you be able to compare between the two.
Well, I would say that progress, that's exactly why we did progress, is because we feel that there are what we call significant AS with symptom or damage that are mislabeled as moderate, but they smell like severe. And they're significant. It's like a coronary lesion. Okay, you have a 70% with no symptoms, you have 70% with heart failure or chest pain. So I think we need to redefine the severity of AS because those flow-derived gradient. AVA is not a measurement, it's a reflection of the LV work. It's the Bernoulli equation, and this is flaw, like there's not more flaw equation in life than the Bernoulli equation. So it's not a distance, it's literally LV work. So we need to redefine AS severity. So that's on the to-do list. So.
Yeah, I think that's a good point. We could spend the next hour debating this. But I agree, Ron, just using mean gradient criteria is not the right way to do it.
Yeah.
And we're looking now at, we're looking at mean gradients, we're looking at AVI indexes, we're looking at peak velocities, DVI, everything. And with that, looking at the echo and having an expert looking at it and trying to determine if they have significant, within that range of what we call moderate. But it is tricky for the clinical trials. One quick question.
Yeah, good morning. I just want to ask what are your takes on, for moderate AS patients, do y'all, or any of y'all do a CT aorta to assess the aortic calcification and to see the severity, whether it is a severe AS or moderate? Thank you.
Yeah, so in progress, we have calcium score assessment in all the patients. And I think that's in the guideline, but that needs to be refined. That said, women have more fibrosis, and sometimes you can see in tricuspid valve, they're severe by gradient and AVA, but they don't have a lot of calcium. On the other hand, bicuspid has a ton of calcium, and sometimes they're moderate. So it's not perfect neither. So.
Yeah, but we all did CTs. In fact, CTs were qualifying studies to be sure that they were at least candidates for TAVR. And that issue of not having enough calcium is a very interesting issue in the moderate group. And as Philippe said, it's more common in women. Speaking of which, we're fortunate to have Alexandra Lansky, who's joining us, and she's going to shed some light on this controversial issue of CEP by talking more about some of the other surrogate endpoints in TAVR trials, and to explain to us if they are clinically relevant.
Thank you, Marty. Thank you to the organizers for the kind invitation. The discussion here is absolutely fascinating, and I think just my 2 words on it, I think the concept of an acute valve syndrome is one that we need to talk to our guideline folks to change the recommendations. Okay, we're shifting. There's a debate coming up, so this is kind of a prequel to the debate. In many ways, I'm going to be talking about brain MRI as a surrogate endpoint in TAVI trials. Here's some disclosures. So, quick introduction. I think the stroke rates have been relatively constant. We've seen this. This is from the United States in the TVT registry. Ever since the approval of TAVI, about 2.5%. This is reported by the sites. We know it tends to be underestimated, but this is in the context of lower risk patients being treated for TAVR. Can we prevent stroke with CEP? That's the topic of the debate, but there is currently one device that is approved in Europe and in the United States. That's a Sentinel device. We've seen that it was safe. We saw that it was safe in the IDE clinical trial, but it did fail its primary efficacy endpoint based on diffusion-weighted MRI. There was a 40% reduction in stroke, but it wasn't significant. We went on to see the results of the protected TAVR trial, 3,000 patients. This was a very pragmatic clinical study looking at all stroke at 72 hours. Again, it failed the primary efficacy endpoint. There was some really interesting secondary endpoints in there with a benefit in terms of disabling stroke, but nonetheless, the primary endpoint was not met. And then lately at the ACC, just a few weeks ago, we saw the results of the BHF Protect TAVI, and again, failed efficacy endpoint. So it's safe to say, in the context of this first generation CEP device, it has been underwhelming in terms of the efficacy. It's also safe to say that doing randomized clinical trials of close to in totality, 10,000 patients is really not feasible for new devices coming down the pike to look at this. This is a very small study, but has been replicated in multiple different studies looking at brain injury. And I think it's safe to say that the vast majority of patients undergoing TAVR have brain injury and sizable extents of brain injury. This is the Neuro-TAVR, about 300 cubic millimeters of brain injury based on diffusion-weighted MRI done between 2 and 5 days. That's not good. And the question being posed here is, what does this mean? Does the brain MRI injury actually discriminate stroke after TAVR? And here are two examples, and you can see they're quite different. The top one has few lesions, but they're bigger. The low one has multiple lesions, but both these patients have more or less the same amount of brain injury in totality, and their outcomes are different. So the question is, which one of these measures, if any, are relevant? So to try and address this question, what we've done is a patient-level pooled analysis of 4 clinical studies that we conducted using similar methods, similar protocols for diffusion-weighted MRI, same core laboratories, CEC, neurologic assessments, etc. And we ended up with about 500 patients with diffusion-weighted MRI, serial neurologic evaluation, and very high follow-up of 97%. So here you can see the outcomes of this population. You can see the difference in outcomes when you have such surveillance. So the ischemic stroke rate here was about 7%. The fatal or disabling stroke, 3%. And overall, 85% of these patients had brain injury based on diffusion-weighted MRI. And interestingly, 84% of patients that did not have a clinical stroke actually had evidence of brain injury. So this is, a little bit of statistics here, but what we did to try and identify which one of these measures were relevant in terms of discriminating subsequent ischemic stroke is we used ROC analysis. And you can see that every single one of these measures is actually good in being able to discriminate subsequent ischemic stroke at 30 days. The best measure here is the total lesion volume with the highest C statistic, and we identified a cut point, the cut point in terms of the extent of brain injury that has the highest sensitivity and specificity for ischemic stroke. We did the same thing for disabling stroke, and again, you can see the TLV has the strongest ability to discriminate subsequent stroke with a cut point here of about 1,000 cubic millimeters. And if we now look at that cut point of 500 cubic millimeters, you can see that the stroke rate is about 10-fold higher. Disabling stroke was about 10-fold higher. And there was better stroke recovery, so there was prognostic benefit when you looked at patients with lower ischemic brain injury. The other thing we looked at was whether or not the STS actually predicts subsequent stroke. And what we can say here based on patients at low, intermediate, and high STS risk, there was no relationship with stroke, no relationship with disabling stroke, but as promised, the STS score does predict mortality. It did not predict either the extent of brain injury based on diffusion-weighted MRI. So the future, we're going to be hearing about this in the debate. There are a number of new devices that are currently being evaluated, Emboline or Emblock, Protembo, all being evaluated in randomized clinical studies. We're going to be seeing a lot more on those coming up, and then a number of other devices in earlier stages of evaluation. So stay tuned. PCR, we're going to be seeing the pooled patient analysis of both PROTECT TAVR as well as PROTECT TAVI from the BHF. I think we're going to be learning a lot from that. TCT 2025, we hope to be able to present the Emboline H2H randomized clinical study And then going on to 2026, again, some exciting work with Protembo and M-Block. So a lot of work coming out and a lot more to learn on the topic. Thank you very much.
Alex, that was terrific. We'll get back to a panel when we finish this group of talks. And now let me introduce Ho-Jin Kim from Asan Medical Center. And he's going to talk about a vexing problem that we all still have, less frequent than before, but non-femoral TAVR approaches. From his perspective, what are the best?
Thank you for the opportunity to speak. In this talk, I will cover the just overall landscape of non-transfemoral TAVR access options. So this is my disclosure. So the TBT registry shows that transfemoral TAVR remains the gold standard, accounting for more than 95% of all cases. Just non-transfemoral TAVR is only selectively used whenever transfemoral TAVR is not feasible. So this table outlines the most commonly adopted non-transfemoral access: transapical, transaortic, and transaxillary, transcarotid, and transcaval. And in this talk, I will cover the initial four approaches. Transapical or transaortic, just access is gained through the intrathoracic spaces, thus requiring the limited sternotomy or mini thoracotomies. So due to its direct access to the ascending aorta or apical myocardium, these approaches are inherently more invasive. So in this meta-analysis of 18 studies involving more than 11,000 patients, transapical or transaortic approaches is associated with a higher rate of 30-day or 1-year mortality compared to the extrathoracic vascular access route. And these approaches also carries the higher rates of complications such as stroke, atrial fibrillation, or acute kidney injury. Therefore, just current guidelines recommend favoring extrathoracic vascular routes over transapical or transaortic. So among all extrathoracic vascular access, transaxillary approaches has gained popularity until the late 2010s. And compared to the standard transfemoral approaches, transaxillary TAVR showed a comparable device success rate. However, this approach was associated with a longer procedural time and higher rates of conversion to open surgery or cardiopulmonary bypass use. It also showed a higher rates of all-cause mortality and stroke. And notably, just transaxillary access showed a higher rate of stroke even compared to the transaortic or transaxillary, which was also confirmed in the other studies. The transcarotid artery offers a convenient access due to its ease of surgical exposure and favorable angle to the ascending aorta. And in the analysis of a TBT registry involving almost 4,000 patients who received the balloon expandable TAVR, transcarotid TAVR was associated with a comparable 30-day mortality, but it showed a lower rate of stroke compared to the transaxillary TAVR. And a similar pattern was also observed in the TBT registry data involving self-expandable valves. The stroke rate still remained high with the transaxillary approaches. So compared to the standard transfemoral TAVR, in this meta-analysis of 4 studies, transcarotid TAVR showed a comparable 30-day MACE, mortality, and stroke. So therefore, transcarotid TAVR surpassed the transaxillary TAVR and just remained the preferred option of non-transfemoral approach in North America. So in line with this trend, our institution also initiated balloon expandable transcarotid TAVR in 2023. Our first patient was an 81-year-old gentleman with multiple comorbidities. His STS score is 6.7%. And as shown in the CT findings on the right, TF TAVR was not feasible. So we approached through the left carotid left carotid artery. I will not cover the detailed procedural steps. And just procedure time was 2 hours, 24 minutes, and patient was discharged to home on post-op day 6 without complications. So in our institution, transapical TAVR has been a preferred approach, non-TF TAVR until 2021, but since 2023, we have adopted the transcarotid TAVR as a non-TF TAVR options. So in summary, transfemoral TAVR remains the gold standard, and transapical or transaortic TAVR is associated with a high risk of mortality and morbidity, so its use has been declined. And transcarotid, transaxillary now remains the preferred non-TF options, although higher rates of stroke has been documented with transaxillary routes. Thank you for your attention.
Why don't you do this?
Okay.
Much more smart.
That was very interesting. If we have time, we should discuss just a little bit more. But we're now going to ask our friend Gilbert Tang from Mount Sinai in New York to talk about a familiar topic, Redo-TAVR. And he's going to give us, in 8 minutes, he's going to give us all the tips, tricks, how to plan and execute this very exotic procedure.
That's why it's like an 8-minute trailer, right, to a 2-hour movie. But on behalf of Vinny, Bapa, and others, I will try to do my best to just talk about how to simplify this procedure because it's coming to the doorstep near you. So we're going to go about procedural planning, how to implant these, and how to standardize the procedure. So if you haven't done so, download this app on Android, Apple. This is developed by Vinny and Miho. It's been very useful in terms of planning. I've also done some teaching online as well, such as this video, which is kind of predicated on this. So we know there are basically 4 different combinations for TAV and TAV, short and short, short and tall, tall and short, tall and tall, just to make it simple for everybody. In reality, actually only two scenarios. Second valve is short or second valve is tall. That's what really you need to know. And so there are 4 key concepts in the planning. I just put it on one slide. So number 1, know your devices, where the commissural posts are. The second concept, this neo-skirt plane, basically, if the second valve is tall, the skirt planes can be at the commissural post of the first valve. If the second valve is short, though, it depends on where you put it in because it changes with the position. Third concept is this coronary wrist plane. It's basically the base of the coronary, take off the lowest coronary. And that's important because you need to evaluate basically the margin between the coronary wrist plane and the neo-skirt plane to determine coronary obstruction risk. Other things you need to know is how do you size the second valve depends on actually what the CT sizing is, particularly if you talk about short and tall combination. The pre-index size CT is important in my mind because you have to optimize the first valve and also the second valve. And finally, putting it in what we call a frame alignment view and fluoroscopy really helps you out. So first step is how to figure this out in terms of what the zone is. So rather than going through on CT, which will take another talk, fluoroscopically, you can actually see where you're going to land. So for example, in this particular case on the left side, the top of the neo-skirt plane is really where the commissural tab is located, and then the coronary takeoff is here. So you need to look at where this blue zone is in terms of coronary obstruction risk. The right side is an evolute valve. You can see that here. Again, similarly, this is the top of node 6 versus the coronary wrist plane at the base of the left main. So you need to measure this. If this is not sufficient in terms of coronary obstruction, then you need to put the second valve deeper to clear of this neo-skirt plane. Second step is how do you identify where you're going to put the second valve. So again, back to this figure, you have to look at where the coronary obstruction risk will be. And the problem is that, you dilate the first valve and actually can reduce the distance. And when your second valve is short, your first valve may actually also expand. So in a short and tall combination, also the short valve can move up. And so your risk may actually be worse than you think. And so these numbers that we talked about here is really just an estimation based on CT because the valve can change. And so you need to think about a liberal approach in terms of coronary protection. So the third step is you really want to optimize the landing zone for your second valve. So in our opinion, that you need to pre-dilate the first valve. And so what we've seen in the literature is that if you put 2 valves in, you really can't expand the second valve much more or the first valve much more. And most of the first valve degenerate because of underexpansion. And so for a short valve, you pre-dilate them can actually make the landing so more favorable for the second valve. And then if you use a tall valve with stenosis, it makes crossing that valve easier. So here's an example here. You see a short valve, underexpanded position. And you can see by pre-dilating, you clearly see fluoroscopically expanded more. So whichever second valve you choose is going to be better off in terms of expansion. And this is a tall valve here. You can see what we pre-dilate here because the valve is very stenotic, so it might be difficult to track in terms of crossing it and positioning, so we thought this would be helpful. So how do you put the second valve in? And really, you need to think about what your combination is. It's just 3 representative combination of 3 different valves, and you need to see how you actually position it. But in summary, this tall and short combination is pretty straightforward because you need to just basically put the second valve in a short valve in terms of more the outer curve, so you make it more symmetric deployment. So what I mean by that is that look at this first example here. If you're not coaxial, you end up high on one side and deep on the other, and when you release, you might risk pop out or unintended consequence. Versus in the second position, you can see it's much more symmetric in terms of deployment. On release, it'll be a little bit more predictable. Now, short and short, you can see that people think might be easy, but actually, you have to be more coaxial as well because if you especially worry about coronary obstruction risk, and we learned to do extremely slow inflation to account for movement because it's not the same as native TAVR. So for example, here, you can see the risk plane is quite high, so we intentionally put the valve in a little bit deeper. In a short and short combination, you can see that how it might end up. Now, short and tall is probably the most challenging combination, and so we need to figure out where you plan to target. However, you have to also think about obstruction risk. Just because you start in a certain node doesn't mean that you'll end up there. And so you need to use a wire to your advantage rather than the upper one push and pull because actually it might be harder than you think. So here's an example here. You can see where we start to deploy. And you can see that this one particularly land roughly at where it is. But you can see actually on the left side, it canted a bit upward. So you have to account for that, and you might actually have to pull the wire to let the valve drop or push the valve, let the valve ride up if the valve starts to go deeper. Finally, I think you have to post-dilate to optimize the second valve. So what we've seen here is the short and short combination. We like to post-dilate again just to make sure you have apposition between the 2 frames because sometimes these leaflets of the first valve can be quite thick. And you can see that here with a tall and short combination, you want to maximize the supraannular benefit of this particular combination. And then finally, in short and tall, you can see that here, you also want to minimize the gap. And we've had anecdotal evidence that if you don't post-dilate, the next state of valve migrate to the ventricle. And so that's definitely what you don't want. And so we liberally post-dilate this with the understanding you may actually still risk obstruction because you might expand the first valve more. But if you don't, you might miss migration if you don't appropriately size with these 2 combinations. So in summary, you can see that we've now, at least in our institution, standardized the workflow of these procedures. We like to do this frame alignment view to take the parallax out and overlay all the diamonds and cells. And then we pre-dilate the first valve to optimize the landing zone of the second one. You want to optimize the trajectory and alignment with the first valve. And we also try to post-dilate the second valve whenever safe to do so to avoid migration and also optimize the expansion. Thank you.
Thank you, Gilbert. That was terrific. It's a challenging procedure, and even though you've explained it beautifully, I wonder if every center, has the ability to be able to apply that level of rigor in terms of making every decision to optimize outcomes, and that would be an interesting question. So we're going to end this session of talks with Duk-Woo Park, who's one of our great friends from Asan Medical Center, and he and his group have done some really seminal work on optimal antiplatelet therapy in TAVR, and he's going to explain to us why there are no more debates.
Thank you, Marty. And my talking is about, this is a real issue about contemporary anti-thrombotic therapy in TAVR procedure. This is my disclosure. Really, leaflet thrombosis was issues that was published in New England Journal of Medicine 10 years ago. After release of this article, there are issues about the leaflet thrombosis could be, real risk of thromboembolism, and the NOAC and role was revisited in this valvular thrombosis. This is valvular and perivalvular thrombosis is not rare. This is very often after TAVR. This is an invited editorial to publish in our article and showing the subvalvular and the supravalvular and the perivalvular. This is our published article in the ADAPT TAVR and the subgroup analysis. Very often, and the leaflet thrombosis is 14%. Overall, any thrombosis, including leaflet thrombosis, supravalvular, subvalvular, and the sinus of Valsalva, nearly 43% is quite common in our TAVR practice. We know the very dynamic pattern of a leaflet thrombosis without anything do, and the leaflet thrombosis develop the halt, RAM, and then regress and halt, and the normal leaflet, there was a more exaggerated with the use of oral anticoagulation. So, and we know subclinical leaflet thrombosis, this is common is after TAVR procedure, but OAC can reduce leaflet thrombosis. There is a known knowledge, but we don't know, and this is a real causal relationship with the leaflet thrombosis with the cerebral thromboembolism. Also, we don't know OAC can reduce the leaflet thrombosis related to cerebral thromboembolism. This is one of a randomized trial in the ADAPT TAVR trial published in Circulation Journal. We found and the edoxaban compared to the antiplatelet therapy, positive effect on DOAC in the leaflet thrombosis, but no effect on cerebral thromboembolism detected by MRI, and no effect on the DOAC on the neurological function. So, and we know that if we're going to use NOAC in the Galileo 4D trial, Atlantis 4D trial, absolutely reduce leaflet of leaflet thrombosis. But in the TAVR patient can see the forest for the tree. Leaflet thrombosis is imaging phenomenon. We should consider patient itself rather than imaging concern. The reason why the TAVR patient is some different and combining frequently thrombotic risk as well as bleeding risk. Is why antithrombotic is a strategy for TAVR is so complex. This is not really simple. In the relatively young patients, in the antiplatelet, anticoagulation is very well balanced and ischemic at bleeding risk. But the TAVR patients, is elderly patient, is clustering effect and fragile elderly patient, mortality, ischemic event, as well as bleeding event. And until recently, over the 10 years, many trial was done in the random trial. This is some summary in patient without OAC indication comparing single antiplatelet, the depth therapy, ARTE, and popular TAVI trial. There is no difference of ischemic outcome, just bleeding event much higher in the depth therapy. This is a randomized trial OAC evaluation without the OAC indication. Galileo trial, Atlantis trial absolutely shows a triple hazard, bleeding much higher, mortality much higher, as well as all primary composite much higher in the OAC compared to the antiplatelet therapy. And with the OAC indication, popular TAVR trial is published, and the OAC alone versus OAC clopidogrel, and no difference of the ischemic outcome, but bleeding event much higher. This is also tested Atlantis trial, Envisage TAVR trial, even in patient with OAC indication, and the bleeding event is comparable. Even in the Envisage TAVR trial, non-cardiac death much higher, and there was some neutral effect of OAC, even in patient with OAC indication. This is a most updated guideline recommendation in the European guideline and the US guideline, consistently recommended single antiplatelet therapy would be okay without OAC indication. With the OAC indication, oral anticoagulation, mainly DOAC, would be okay. There was class 1 recommendation. They don't recommend it. OAC is not recommended for TAVI without OAC indication. Absolutely, given no definite association halt and cerebral thromboembolism and consistent guideline, simpler is best. So my summary, optimal antithrombotic strategy after TAVR leaflet thrombosis has not been proven to directly affect thromboembolic event. This evidence do not support imaging-guided antithrombotic strategy in most cases without hemodynamic and clinical relevance. cumulative evidence of random trial consistently shows no benefit of a DOAC with considerable hazard, especially bleeding risk, in patients without OS indication, and the neutral effect in patients with the OS indication. Early TAVR patient, absolutely elderly TAVR patient, totally different compared to relatively young ACS and PCI population in terms of ischemic bleeding balance. Less is more concept of antithrombotic therapy would be optimal most of the TAVR patients. That was adapted in the contemporary guideline. Absolutely one single final message, treat the patient, not the valve step, and to make it simple. Still remaining issue, the long-term impact valvular or perivalvular thrombosis, the rate occurring thromboembolism or valve durability remain uncertain, and the TAVR patient is not single scenario. We should consider relatively young patient, age 70, less than age 65, less fragile patient. Still many physicians use DAP or DOAC, and the complex anatomy such as bicuspid and the calcium chunk or concomitant coronary artery. We have some different options. As in terms of lifestyle management, valve in valve, in the TAVR in SAVR, TAVR in TAVR, and many physicians still more prefer the more potent antiplatelet therapy. Thank you for your attention.
Okay, thank you very much, Dr. Wu. Excellent and very precise. So no more debate, I understand. So now we come to a debate, which is a very controversial topic. Use of SAP in contemporary TAVR practice. We have a yes and a no. What the... you switched?
Just to keep you honest, yeah, no, Philippe and I discussed ahead of time, if that's okay. We thought it would work better.
Fine.
We thought it would work better. It was Philippe's idea, not mine. Can we go to the next ones, though, so we can go? Sorry, Eberhard. Yeah, we just wanted to kind of...
No problem. And we're going to combine the discussions because we're running just a little bit late. So we'll do the debate, then we'll have a discussion, and we'll discuss the debate and the preceding talks.
Okay. Just need to get the switch to the next part.
So you see, it's not only me that's confusing. Okay.
No, I'm not Philippe Genereux. That's the problem. Can you go to the next talk?
Next talk, Dave Cohen.
I told you this would be more interesting, though, if I talked to your slides and you talked to mine.
Yeah, well, I have to tell you, it's very hard to defend the pro, so let's start with a no.
Can you switch to the next talk, please?
That would be easy.
Thank you, DW. Here we go. So this should be interesting. I'm always giving debates. I don't know why people think I like debates for some reason, but this is a good debate, I think, and an important one in light of all the discussion that's gone before about whether we should use embolic protection devices routinely in contemporary TAVR. And the answer that I've been asked to defend is no, and these are my disclosures. So I give a lot of debates, as I said, and usually I get a very unpopular topic, and I feel kind of like this prisoner here just being led to the executioner. And then I was asked by the organizing committee here to give a debate where I felt very different. And this is how I reacted when I got the invitation to give this debate, was, oh, now finally I get to relax from it. So I'm going to try to look at three things to understand whether cerebral embolic protection devices prevent stroke. So I'm going to look at the evidence from well-powered randomized clinical trials. There are 4 randomized clinical trials in the space of with the Sentinel device against standard medical therapy. Alexandra already did the perfect job in summarizing these. I'm going to do it in a table rather than with figures. The clean TAVI was the first study, which was 100 patients randomized, and they used a number of brain lesions in protected territories by DW-MRI, and it was positive. It showed a benefit. Then came the Sentinel trial, and Alexandra spoke about this, which looked also at a DW-MRI endpoint of new lesion volume, and it was neutral. And then along came protected TAVR in 2022, 3,000 patients now, stroke within 72 hours, neutral. And then just last month, the BHF Protect TAVI trial, 7,600 patients, stroke within 72 hours, and it was neutral. And as Ron Waxman, who's been sitting next to me, kibitzing with me the whole conference here, said, 3 strikes and you're out. And I think it kind of feels that way for this device. It's just hard to justify using a Sentinel based on these randomized trials, but Philippe will try. What about meta-analyses? Some people like those. Here's a meta-analysis of all the cerebral embolic protection devices except for the BHF Protect TAVI, which we know was neutral. For any stroke, 8 trials, 4,000 patients, a neutral result. It's not going to change with the addition of another neutral trial to it. What about the Sentinel? Again, there's a trend towards benefit, but it's not statistically significant in a meta-analysis. It is only going to get weaker when you put in the Protect TAVI trial. So I think meta-analyses are equally clear. So I want to spend a little bit of time on what I've spent the last 5 years trying to do, is to see if we can get what I consider to be high-quality evidence from observational studies to answer this question. And we started doing this several years before any of the big randomized trials were out, because again, I was really convinced I was going to show that there really was a big benefit here. So this is our most recent effort. This was done and published about a year ago, about a year before Protected TAVI came out, from the TVT registry of 440,000 patients who had a TAVR over a 5-year period during which Sentinel was approved in the United States. After a small number of exclusions, we had 414,000 patients in our analytic cohort, and of those, about 50,000 got an embolic protection device, and about 360,000 did not. Now, the normal way people would analyze this is to compare these patients in the blue against these patients in the red, but we know those analyses are confounded and have a lot of problems. And so the analysis that we did, and one that I'm quite fond of these days, is using something called an instrumental variable analysis, which comes from the economics field, and it takes advantage of natural experiments. Now, what's the natural experiment in TAVR that it changes the exposure to embolic protection? And the answer is which hospital you go to. And I'll show you those data in just a second, but we kind of knew this was going to be the case because we know there are centers in the United States that really are committed to using embolic protection in all their cases, and then there are a lot of centers that don't use it at all. And under appropriate assumptions, which we believe were met in this study, this is a technique that can account for both measured confounding, like we do in typical observational studies, but also unmeasured confounding because it's based on this randomized experiment or this natural experiment. And again, the instrument was the site-level preference for embolic protection use during the calendar quarter. And this is the variation that we see in the United States, and this is why you can do that analysis and get reliable results from it, because there's nothing more random than this distribution. Basically, over that 5-year period, 40% of centers never touched an embolic protection device. 60% of centers used it at least once, but only 6% of the centers, these ones way out here to the left, used it in more than 50%, and you can see the proportions are even a little more skewed in 2023. So there's huge variation here, and we could take advantage of that. And when we look at these instrumental variable analyses, this is what we see when we look at any stroke. We see a very small relative risk reduction of about a 10% relative risk reduction that is not statistically significant, and certainly not statistically significant when you've got 400,000 patients in the analysis. And then looking at disabling stroke, we see a borderline significant reduction with a p-value right at 0.05, relative risk of about 0.9 again. And so we concluded from this study that yes, there probably was an effect on disabling stroke, but it was very small. And I think that may well be the truth. So from my perspective, to summarize what is an awful lot of work by an awful lot of people, there's no question that stroke is important, and it's a significant and unpredictable complication after TAVR. There's also no question that our embolic protection devices, at least the Sentinel device, captures debris. And it may reduce the volume of new brain lesions, although again, if you look at the totality of evidence here, there's only 1 out of 3 trials that actually showed that as well. The clinical benefit of our current embolic protection devices therefore remains uncertain, and I would say if it's present, it's likely to be limited to disabling stroke. We don't even find in that huge study a benefit on all stroke, and it's probably very small with the number needed to treat of about 800 to prevent 1 disabling stroke. And the randomized trial you would need to detect this, as we wrote in that last paper, requires about 120,000 patients randomized. It's been difficult to identify subgroups that receive consistent benefit. And finally, I think here's where I really do agree with Alexandra, is I think we need newer devices. I think this device has been tested well enough. Unfortunately, it just doesn't seem to deliver what we had hoped. And the new devices need to undergo rigorous evaluation. And again, in my opinion, we still need to do them ideally for stroke prevention rather than surrogate endpoints, and maybe we can have a three-way debate on that. Thanks very much.
David, thank you very much. I'm not quite sure why you switched, but anyway, this is good. Now, Philippe, you're taking
Yes. So just for Ron Waxman, I will say that I'm not a baseball expert, but I will not call it strikes. I will call it foul ball. So you're still alive at the plate because I will try to defend the proposition, which could be very quick. So the truth about this debate, I was not very happy when I said a proposition. I rarely use Sentinel, to be quite honest with you. I only use it when I do complex TAVR or mitral. When I use leaflet modification, I cut the leaflet or explode leaflet with balloon. I use it when I do left atrial appendage closure watchman with a clot present, or when I remove massive vegetation from the LV. So I rarely use it. And I spent 15 hours of my 15-hour-and-a-half flight preparing this talk, and I might still lose this debate, which is very a shame, but I will try to convince you. I'm an optimistic by nature, and I will say that the preparation of this talk deeply and profoundly changed me as a person. I may actually influence my future behavior, to be quite honest. And the lack of strong evidences currently doesn't mean that we should give up on patient and how to improve patient outcome after TAVR, especially in terms of stroke risk, but also neurocognitive function in general. So I don't think we're dead yet. I think we should keep trying to swing this ball off the park with different populations. I already concede the win to Dr. David Cohen for now. We have data from 4 randomized trials that do not support the routine use of Sentinel device for neuroprotection among patients undergoing TAVR in the context of a randomized trial. But what about real-world data? High-risk patient for stroke, like I mentioned. What about other devices than Sentinel? And what about your mother? Do you want your mother to have a Sentinel device, a TAVR protected with a Sentinel or not? We went through this. The first one was positive based on brain lesion. The second one was negative based on brain volume, but when we adjust for baseline lesion, it was positive. PROTECT TAVR was negative clinically, but again, decrease in disabling stroke. And BH PROTECT TAV, it was done in UK, was negative, but I think they are the expert of negative trials, so I don't think we should focus too much on the last one. So PROTECT, one PROTECT. Do you want brain lesion? That's the concept. On the left one, there's a big and fat red dot, and which is a lesion. And on the right, there's a less big red dot. And neuroprotection decreased by at least 50% the amount of red dot in your brain. So I think for me, it's pretty clear I want less brain lesion. The other thing, do you want small or large brain lesion? On the left, there's a lot of red dot and they're big. On the right, there are less brain lesion. So, and it's at least 50% reduction in the volume and the number of lesions. So I think it's important to keep it's working. 99% of the time, you capture stuff in the basket. And when you cut leaflet, especially core valve, both basket are full, okay, full of valve debris. So I think before saying no to a neuroembedding protection device, you have to be careful because we're going to see a lot of stroke if we don't protect the brain, especially in special patients. People said PROTECT TAVR was negative. When I see this 50% reduction in disabling stroke, the one we care about, the one patient care about, the one the daughter or the son care about their mother or the father. And when you look at the clinical impact on stroke with Sentinel die less than stroke with no Sentinel. So for me, it's important. Not stroke, all stroke are equal. And when you have a stroke with Sentinel, you're more likely to go back home and be functional compared if you have no Sentinel, which you go in nursing home and you may be disabled and never go back home. So I think the win are in a small detail like that. So to throw the Sentinel or the neuroprotection away, it would be a big mistake for the field. I work in US. So for me, those data are compelling. When you do the geographic assessment, US versus OUS in the PROTECT TAVR, you see a more than 50% reduction in the stroke rate. And this is a sub-analysis that Raj Makar and the group of PROTECT run. Again, 50% reduction in disabling stroke and all stroke when you have a patient in US. I work in US. So I don't care about UK, I care about US. PROTECT TAVI was clearly negative, not even close, okay? I'm not even sure if they run 2 sham control study, but I have to tell you, this study, I'm not sure it's important, especially, for the only reason it might be important for the subgroup analysis. They have a lot of patients. And when you see it may work for self-expandable TAVR, which makes sense. You scrape the aorta on the way up, and when you pre-dilate and you post-dilate, which makes sense, and when you have a lot of calcium on your valve, which makes a lot of sense. So I think from this trial, the silver lining, you see that there's maybe subgroup where you should do it. There's one meta-analysis that Dave didn't want to show, but there's the reduction in stroke, okay, and reduction in mortality. And I think it's important to say that a big stroke will kill you and a small stroke will not kill you. And I think this is where there's a signal that we should not throw the baby with the bathwater. And Dave was a co-author on this, is the senior author. And the last line of the conclusion in the abstract is, these findings provide credible evidence that EPDS benefit patients undergoing TAVR. And this is Dave Cohen saying this. So I think for me, this is data from his large TVT registry with 50,000 patients who has actually a protection device compared to 360 and with not. And they show a reduction, a 13% reduction of disabling stroke, and also 21% reduction when you do propensity weight analysis. Again, a lot of patients, I agree, cost effectively, maybe not very cost effective, but we talk about disabling stroke. And again, the beautiful thing about their paper is they identify patients that may benefit from this. Prior stroke. A patient with prior stroke may need protection. Patient with valve-in-valve, and patient with self-expandable valve. So I think, again, there's a subgroup that may emerge from this that are important. So I will conclude that there's compelling case based on the totality of evidence that we have a proven mechanism. We capture a lot of stuff. We reduce the number and the volume of lesion. We reduce disabling stroke. We have excellent safety profile. We address patient fears and anxiety, which is important in their family. Would be very vital for low risk and young patients, and especially in high-risk subgroup. Prior stroke, valve-in-valve, high calcium score. I think if I had to redo a study, and I have a new device that I just want to launch, I will use a very enriched population of high-risk patients, valve-in-valve, high calcium score, bicuspid, the one that it makes sense. There's other device coming. I don't know if they're going to be more beneficial, but I have to tell you, Sentinel is not the winner because it's only protect 2 out of 3 vessels, and it's cumbersome. You may create stroke when we use it with air or debris. So I think full body protection may be better. Stroke is a terrible complication. I know we talk about that. I think if I need a TAVR or my mother need one, I think I will protect her brain because I love her. My personal opinion is to prevent stroke, focus first, and this is what I do in practice, high-risk patient, valve-in-valve, high calcium score, leaflet modification, mitral, especially when there's a lot of MAC, valve-in-MAC, if you do a Batman or you explode the entire leaflet, it's like a grenade on the mitral valve. This leaflet is shattered, is going everywhere, okay? The brain, the gut, the toes, so you need to protect the body when you do this. And for me, obviously I'm biased, but the most important stroke prevention strategy is to treat the patient early. Severe AS, no symptom, and moderate AS when there's no calcium score on the valve. And this is the ultimate neuroprotection strategy to prevent AFib and to prevent also embolization. And again, I don't want to sound like a broken record here, but in early TAVR, we had 50% reduction in stroke, which is what the wettest dream of neuroembolic protection device. If they could have that, it will still be in business. And also we reduced all stroke from 0.9% to 1.8%, including in the meta-analysis. So I think for me, yes, neuroprotection strategy for everyone, early treatment when there's not a lot of calcium on the valve, prevent AFib and the need for anticoagulation. And actually I will say that use strategy to prevent stroke, such as best-in-class TAVR device, avoiding unnecessary scraping of the aorta, multiple recapture, pre and post dilation, neuroprotection for specific patient, and I think a better neuroprotection device might improve outcome. Thank you so much.
Thank you very much, Philippe. You made your point. Actually, both of you made your points. It's not about who's winning and who's losing. Yeah.
Jian'an. Hi, Dr. Lansky, may I ask you a question? I think the question is also good for the 2 debaters, I think. So, do you follow up your patients with a silent stroke about their cognition change for long term? So that's
Yeah, we've tried very hard, and I think the Sentinel people have tried very, very hard to do serial neurocognitive evaluation. It's a very complicated thing, and there's so many. If we think they're confounders in TAVI, there are so many confounders when you're looking at neurocognition. I mean, it's an aged patient population, there are multiple factors, risk factors, et cetera. So it's just very, very difficult. And we haven't been able to really, nail the right measure for cognitive dysfunction. But I agree with you. I think it stands to reason that if we're, causing so much injury to the brain, that it must, over time, have some impact on cognition. Just my vote, I think Philippe, you win.
Yeah.
Well, again, there are no winners or losers, but David is allowed a very, very quick rebuttal.
Oh, I don't think I need a rebuttal. I think I agree. I was standing up mostly to talk about the neurocognition issue, which, again, Alexandra described that it's been looked for and hasn't been found yet. It's very tantalizing, and there is evidence in the neurology literature that increased numbers of white matter lesions correlates with neurocognitive impairment. So I think it's a tantalizing hypothesis that's not yet been proven. Again, with respect to the embolic protection debate, there's no question. 3 years ago when the original protected TAVR trial was released at ACC, there was a poll among the discussants, like who would want to use this for their family member, and everybody's hand was up for that because it isn't harmful. There's no risk of it. But it costs $3,000 every time you use it, and there are other things we could do for $3,000 every time we use it that are proven to work. And so I would say we should do the things that are proven to work when it costs money, and we should try to prove the other things so that we can justify the cost.
So why don't we do this just to close out the session? Let's ask all of the panelists. You have 3 choices. Yes, I would use it systematically in all patients. No, the data is insignificant, I would not use it. Or third, which is kind of the middle position, I would use it selectively in some patients. So, Philippe, start.
I will use selectively, but in a lot of patients, a lot of selection.
Okay, all right.
Middle position.
Middle position.
The third option, yeah.
Selectively.
Selective, yeah.
Alex?
I want a better device, but if I don't have a choice, I'll use it because I think what it does is it prevents the big strokes and disabling stroke, et cetera, the big lesions.
Okay, Junbo, all of China is waiting.
At this moment, maybe not necessary. Maybe in the future. I think the event occurs there. And why this stroke happens is something debris falls down. The result is we debate is the device today not maybe so effective. That doesn't mean in the future.
Yes, no, or
this
selective? No.
At this moment, no.
No. Yes.
Cost effectiveness is very important
Yes.
in medical decision. Thus, I prefer selective usage.
Selective. Eberhard?
Yes.
Yes.
Maybe no. From our study, we didn't see the cognitive. We follow up patient for a long time. We didn't see most of cases is silent stroke. From our long-term follow-up study, we didn't see the cognition change. Even the cognition is improved because of the hemodynamic change. So okay.
Yes.
Well, yes, selectively.
Yes, selectively.
Yes, selectively, but in special cases like leaflet modification and surgical valve balloon fracture, in our experience, we are almost seen very heavy calcified large debris. So I think in that selection, we have to do almost everyone, but other patients selectively.
Marty, same point, selective, but we were part of protected TAVR, so we don't care about US. In Australia, we did better than Australia. Point 1. Point 2, I do agree that we need better devices, right? I mean, it seems that this device doesn't work, and maybe this is almost a Starflex PFO Sentinel moment where we need a better device like Alexandra mentioned.
No, this is very, very interesting. I think that the data is very clear. I think we have some strengths and weaknesses in the data sets. There's no question that we haven't found the best device yet. We need to see if there are better devices. And there is what appears to be a growing argument that selective use, even though we haven't really shown that with the clinical evidence, is something that people can live with until we have additional data with more devices. So I want to thank the panel for really some great talks. Eberhard, as always, for his intriguing co-moderation. We're now going to reconvene to the main arena because I believe they have the opening ceremony at 10 o'clock, and we all don't want to miss that. Thank you.